Welcome, everyone, and thank you for attending today's webinar on pregnancy and women with intellectual and developmental disability. Next slide, please. Please hold your questions and answers to the end. You can include your questions in the chat box at the bottom of your screen. And at the end, we will also provide you with a list of resources on this topic. We additionally, throughout the webinar, will provide closed captioning, and you can activate closed captioning at the bottom of your screen by clicking on the CC Show Captions button. We are recording this webinar, so you should be aware of that. And at the end of the webinar, you will see in your chat a link to an evaluation. We would really appreciate your feedback. We take your feedback very seriously and really work toward continuous quality improvement with our webinars. Next slide, please. For those of you who may be using ASL interpretation, you can make the ASL interpreter larger by taking your cursor, placing it over that little bar right there in the middle of the screen. The red arrow is pointing to it. Hold down your cursor and pull it over. Just pull it over to the left, and you will see that the interpreter will become larger. The interpreter and the speaker will become larger, and the slides will become smaller. Next slide, please. As I mentioned, we also have closed captioning. And today we're just going to use the chat for questions. Next slide, please. Our speakers today are Dr. Susan Ernst, who is a professor of medicine at University of Michigan, and Melanie Ornstein, also Dr. Melanie Ornstein, also a professor of medicine at University of Toronto. And we are very grateful to our speakers today for joining us and sharing their wealth of experience and wisdom with us. I'm Linda Long-Belisle. I'm an assistant professor at the E.K. Shriver Center and Department of Family Medicine and Community Health at UMass Medical School, and I will be your facilitator for today. Next slide, please. Our learning objectives for today, what we hope you come away from the webinar learning is we would hope that you'd be able to describe issues of societal misconceptions and biases about sexuality and reproductive health care needs in this marginalized population. Explain the diversity of this population because there are varying degrees of cognitive impairment. And describe approaches to reproductive planning, contraceptive counseling, preconception counseling, antepartum and intrapartum care, along with postpartum care in women with IDD. And lastly, explain the special needs of women with IDD with accessing and receiving reproductive health care, including obstetrical and postpartum care. Next slide, please. And I'm going to turn this over now to our first speaker, Dr. Susan Ernst. Doctor?
Yeah, good afternoon, everyone. I'm Susan Ernst, and I have been the director of our gynecology reproductive health clinic for adolescents and women with disabilities at the University of Michigan for the last 18 years. I also not only have this as an academic interest, but I have a daughter who is now 26 years old with Angelman syndrome, so has intellectual and developmental disability. So I speak as a clinician, but also as a parent. So we're going to talk a little bit about the spectrum of disability. When we talk about, women with disabilities or patients with disabilities, we're lumping a whole diverse group of people into one category. And there are different definitions and models of disability. The medical model of disability is espoused by the CDC and says that disability is a physical, a sensory, or a mental impairment that limits one or more of major life activities and makes it difficult for that person to interact with the world around them. However, more disability advocates embrace a social model of disability, meaning that there's an interaction between a person with a health condition and their environment, which may be inaccessible, like inaccessible facilities, stigma, low social support. So it puts more responsibility on the society and the community to change the environment so that the person with this health condition can interact appropriately with their environments and be included in the normal social activities and work activities. So again, in our clinic for adolescents and women with disabilities, we see patients with a large diversity in the spectrum of disability. So we see patients with only intellectual disability or cognitive impairment. We see patients with only physical disability, so spinal cord injury or amputation of a limb. We see patients from mild to severe involvement, like with cerebral palsy. Some of our patients have only a mild abnormality in their gait, and others have severe physical disability as well as cognitive impairment. Some of our patients are fully independently functioning, working as lawyers and social workers, and others are in need of full-time assistance for all of their activities of daily living. Some of the disabilities are present from birth, and others are acquired later in life. So again, this is just to say that there's great diversity when we're talking about patients with disabilities. In addition, we have to think about other intersecting identities that patients have. We have patients from other marginalized population, indigenous community, new immigrants to our country, patients who have English as their second language, patients experiencing homelessness, patients who are substance users, patients who are developmentally disabled, patients who are trans or gender non-conforming. We have patients with lower socioeconomic status, and we have patients ranging anywhere from age 7 to age 85, so the very young to the very old. And so again, when we're treating individuals with disabilities, we have to recognize these intersecting identities and treat patients with individualized, non-biased medical care. So in accessing reproductive health care, there are barriers and challenges that are multifactorial for this population, socioeconomic, accessibility, and a variety of other healthcare needs. And this slide will really talk a little bit more about those barriers. So we see for patients with disabilities accessing healthcare facilities that there may be physical barriers. There may be inaccessible facilities or exam tables that don't raise and lower for patients with mobility challenges. There's also mammography equipment that's not accessible for patients who are wheelchair users. Our patients often experience stigma or cultural beliefs that don't value patients with disabilities. And patients present to our clinic having experienced embarrassment and shame in other healthcare environments. There are attitudes of healthcare providers that do not treat patients with respect or listen to them. I've had patients come to me and say they had a provider who did a hysterectomy on them, and that healthcare provider never addressed the patient face-to-face or one-on-one. They always spoke with another family member or looked to caregivers to answer questions for the patients instead of directly communicating with them. I've had other patients who said one of my patients had visual impairment and she was pregnant. And a nurse said to her when she was in labor and delivery, "I can't believe you're going to pass your disability onto this child," which was just not very educated statement to say. This patient experienced visual loss due to an infection in their eyes, and it had nothing to do with something that would be passed on to a child. And so our training needs to be better for healthcare providers, as 81% of medical students have no training in disability care. 75% of medical residencies have no experience in disability care, and 44% of OBGYN clinics report being unable to provide care for people with mobility disabilities. And so we need to do better. At the University of Michigan, we now have a Center for Health and Wellness, and we have a fourth-year medical student elective that helps teach students how to interact with patients with disabilities and about healthcare disparities for patients with disabilities. And we also have interprofessional education courses that teach nurses, physical therapists, pharmacists, residents, medical students about caring for patients with disabilities. Sorry, this slide tends to get stuck. So we see different healthcare disparities that occur in populations with disabilities. Patients with disabilities often have higher rates of obesity. They're more likely to be cigarette smokers, and they're less likely to get good physical activity during their leisure time. In addition, adolescents who access special education are more likely than their peers to drop out of school, to have lower self-esteem, to experience greater loneliness and emotional distress, and to develop mental health problems. When we're looking specifically at sexual and reproductive health, again, the healthcare disparities continue. Patients with disability, and specifically those with intellectual and developmental disability, have higher rates of physical abuse and sexual assault. We could talk for an entire hour just about that. There are higher rates of sexually transmitted infection, lower rates of cervical and breast cancer screening. These patients are less likely to receive pelvic exams at regular intervals. They have unmet needs for contraception, preconception, and pregnancy counseling, higher rates of female sterilization and hysterectomy, and unfortunately, higher mortality for breast and lung cancer. I had a recent patient with spina bifida who was diagnosed at age 35 with breast cancer. And when she went to the oncologist, she and her mother felt that they did not receive counseling on all of the evidence-based treatment options for breast cancer due to her disability. I believe that there were assumptions made about her quality of life, and she wasn't offered the full spectrum of treatment options. And so after the patient came back and talked with me, we talked with the oncologist together, and she was given some different treatment options. So we approach all patients with the guidance of our medical ethics. It's a system of moral principles that apply values and judgments to the practice of medicine. The four basic principles of medical ethics, they're important for all patients, but they're essential to respect when we're working with marginalized groups. And so we think about patients' autonomy, justice, beneficence, and non-maleficence. Non-maleficence meaning do no harm. So particularly for our patients with intellectual and developmental disability, we have to decide, the risks and benefits of treatment and make sure that we're helping provide patient-centered care with choice and autonomy, but minimizing risks and harm. We follow the typical guidelines for gynecologic and reproductive health care from the American College of OBGYN, the American Academy of Pediatrics, and Dr. Ornstein and I actually met at the North American Society for Pediatric and Adolescent Gynecology, where we have a special interest group for clinicians who care for patients with disabilities. And so again, we follow standard guidelines. HPV vaccination should be considered for any person age 11 to 45 years old. STI screening we do per the CDC guidelines because studies show that there are decreased rates of screening and higher rates of STIs for persons with disabilities. Cervical cancer screening, again, we follow for the United States, the ASCCP guidelines. Because multiple studies show that there are lower rates of pap smear testing than in the general population. We consider menstrual suppression for premenstrual symptoms, such as mood or behavioral changes, heavy menstrual bleeding, and difficulty with menstrual hygiene. We'll talk a little bit more about this, but in our clinic for adolescents with disabilities, we have a large number of patients whose parents bring them in even before they have menarche, so even before their periods start, so that we can give the patient and the family anticipatory guidance about what to expect with puberty and what to expect when these patients start their periods. We are fortunate to have a social worker and sexual health counselor who work in our clinic with us. And they help counsel the patients, particularly prior to a physical examination for patients with intellectual and developmental disability. It's really a scary, invasive thing for patients to have their first pelvic exam. And so we have anatomically correct dolls in our clinic. We have pictures, we have videos. That the sexual health counselor can use to educate our patients about what to expect during an exam. And oftentimes, our patients like the dolls so much that they bring it into the exam with them as a little support structure during the exam. They're also allowed to have a support person in the exam with them, a parent or a caregiver or whoever they're comfortable with. Again, sometimes the patient will connect with either our sexual health counselor or one of the medical assistants and ask that they be in the exam with them. For our patients with autism or sensory integration disorder, we try to minimize bright lights and loud noises to help make the exam room and space more comfortable for those patients with sensory issues. We talk the patient through each step of the exam. And I always tell parents or caregivers that, as we first start their very first exam, I say, if she is even able to lay on the table today, and that's as far as we get, that's fine with me. I'm not going to push it and force them to do an exam that they're not comfortable with. I want the patient to trust me, and I need to gain their trust by making them comfortable in this space. And so we let the patient guide the exam with the ability to say no or to stop the exam at any point. Again, for patients who've not been sexually active or are having their first exam, we do a single digit exam instead of, 2 fingers in the vaginal area. Or for patients who are very young, we can do a recto-abdominal exam instead. We do whatever position that the patient needs to maximize their comfort and minimize spasticity. So sometimes that the patient is laying on their side. Sometimes for younger kids, they're in a knee chest position. And for our patients with cerebral palsy, sometimes with contractures, we have to examine them with their legs either straight up or assistance holding their legs to the side. Again, whatever makes them comfortable. We often use pediatric or adolescent speculums to make things more comfortable. And for those patients who have a really tight hymen or those who can't tolerate a speculum exam, we just use a single finger at the vaginal opening and then slide a cyto brush over the finger to collect a blind pap smear. And we've done a study to show that even though there's some decrease in the rate of endocervical cell capture, the pap smears are adequate and sufficient. For STI testing, there are alternatives like urine or vaginal swab to avoid the speculum exam. Then we always try to do confidential interview with the patient, meaning that we talk to the patient alone and we ask them if they're currently sexually active, if they have a partner, if they want to have a partner, if they think they ever want to get married, do they think they ever want to be pregnant? And if they want to be pregnant, when might they want to be pregnant? And if they don't want to be pregnant now, then what would be a good contraceptive option for them? Or if they do want to become pregnant in the future, we look at their other health issues and we talk about what might need to be addressed before considering a pregnancy. We use a visual aid like this from the CDC or the World Health Organization that visually depicts the efficacy levels of different contraceptive methods. So at the highest level, you can see that the LARC methods, long-acting reversible contraception like IUDs or implants, are the most effective methods comparable to sterilization procedures. The next tier down are the hormonal contraceptive methods like Depo-Provera injection, birth control pills, patch, and ring. And then the lowest efficacy methods are things like withdrawal or condoms, because you have to remember to use those contraceptive methods every time you have intercourse. So we just do patient-centered counseling, trying to figure out what might work best for that patient. And our patients with intellectual and developmental disability often have other comorbidities. So it's not unusual for patients with cognitive impairment or intellectual disability to have seizure disorders. So that's something we need to think about when prescribing hormonal contraception. In addition, congenital anomalies such as like heart defects are not that unusual. So again, we use the medical eligibility criteria to help guide our choice of contraceptive or hormonal medication use. When thinking about menstrual suppression for adolescents with disabilities, again, we think about whether they're able to maintain and take care of their own menstrual hygiene, whether they have sensory issues, and again, whether they have other comorbidities that might impact their periods. Patients with trisomy 21 often have thyroid disease. That's something for us to think about. Patients with seizure disorders, if they're on anti-epileptic medications, these can interfere with birth control pill. You can see the chart off to the right that oral contraceptive pills can actually change circulating levels of certain anti-epileptic drugs like Lamictal or lamotrigine is the classic one, and occasionally valproate can have reduced levels when someone is started on a birth control pill. And other seizure medications or anti-epileptic drugs will affect the metabolism of the hormones in combined contraception. So phenobarb, phenytoin, carbamazepine, topiramate. When patients are on those seizure medications, we may have to prescribe higher doses of contraceptive pills to be more effective. And so this is just a larger grid of different options used for menstrual cycle control or menstrual management. So we often use non-steroidal medications to decrease the amount of flow and pain that patients have with their periods. We can use combined oral contraceptive pills, particularly in an extended regimen, to lead to menstrual suppression. The patch and the ring are similar, and all of those, because they contain estrogen, we have to really think about for risk for VTE for our patients with immobility or other medical issues. Oral progesterone only pills, I'd like to just say, I think the published amenorrhea rate on oral contraceptive progesterone only pills is listed at about 20%, but in our study in our clinic, looking at girls from age 10 to 25, we had more like a 40% amenorrhea rate for oral progesterone only pills. So it's a great option for patients who have other contradictions for estrogen containing pills. Levonorgestrel IUD is a great option, lasts up to 8 years, but for patients with intellectual and developmental disability, insertion can be a challenge in the office depending on how they can tolerate a pelvic exam. So some of these patients will put under IV sedation to insert that IUD. Endometrial ablation and hysterectomy lead to basically sterilization, and so these are things that are not first line for menstrual management. And in our state, we're required to get court order or court approval because they lead to sterilization. So this is a study published in 2018, looking at about 10,000 patients and their sterilization rates. And it was found that female sterilization rates were significantly higher among patients with cognitive and non-cognitive disabilities compared to those patients without disabilities. So the odds ratio for female sterilization for those with cognitive disabilities was 1.54, and the odds ratio for hysterectomy was 2.64. And if we look at the age at which these patients experienced sterilization, those with cognitive disabilities were much younger than those without disabilities who were sterilized. So I'm going to turn it over to Dr. Ornstein now to talk about pregnancy and disability.
Hi, thank you very much. So as mentioned, I'm an OB-GYN and I'm a practicing obstetrician. So I have an active obstetrics practice, and I work with a lot of marginalized populations, including the disabled. And the thing about women with IDD is that they are sexually active and they will conceive. And sometimes that's something wanted, and sometimes it's not planned or with support. And so we have to recognize that they are women with often the same degree of relationships and sexual activity and desire to become pregnant, but because of their risk of being higher for abuse, that sometimes this is not a wanted experience. We also have to recognize that there are a lot of sort of ethical considerations so that people with cognitive and or physical disabilities deserve the same medical attention and rights to care as their able-bodied peers. And this requires that we have a much more flexible healthcare provision. And as I go through it, I'm going to be repetitive in terms of counseling, education, and support become really crucial. But with this population, sometimes we have to involve other partners. We have to involve parents, caregivers, family members, partners in a relationship. And so it's a much more team-oriented approach. Next slide, please. So given the diversity of this population, a very individualized approach is necessary. And we have to sort of look at the factors that influence the care of this population, one of it which being misconceptions and societal attitudes. And for that reason, we have to do a lot of education. We have to involve a multidisciplinary team often. We have to allow much more time for appointments. And sometimes as busy clinicians, that becomes very difficult to do. And I have found certainly that I've had to also provide education to my admin support people, my secretary, people who do the ultrasounds in our building, people who take blood. So it's not just me who has to be patient and take more time and explain things, but all the other members of the healthcare team need to be aware sometimes that there needs to be a different approach, a slower approach, a more educated approach. Next slide. So often, I can't do what I would do with my regular population. I'll see you in a month, and then every 2 weeks at 28 weeks, and every week at 35 weeks. I have to have more appointments. I have to have longer times for appointments. I have to be able to explain things very slow, very clearly, use repetition, use pictures. I write out a lot of information for people. And on the other end of it, you have to allow patients to participate in their care at whatever level they are able to, physically and cognitively, to be able to be heard, to be able to ask questions. with that, you have to obviously assess their ability to provide informed consent and that they understand the process. And we have to ensure that their confidentiality, privacy, and dignity are respected. Next slide. So there are a lot of healthcare provider and societal misconceptions around pregnancy and family planning. And we know that a lot of times women will speak to us of their experiences of being told outright or it being implied that they shouldn't get pregnant, that they shouldn't become parents, and they often will express that they feel that they have been discriminated against because of their disabilities. We also know that there's definitely increased rates of unplanned pregnancy, decreased intervals between pregnancy, late prenatal care or inadequate prenatal care, and obviously all of these can impact on pregnancy outcome. So we need to increase our preconceptual counseling, as Susan said. Part of the gynecological end of things is are you sexually active? Are you using contraception? Do you want to parent? When do you want to parent? And then part of the piece during obstetrical care is, can you make it to the appointments? Are the appointment facilities accessible to you? Do you need financial support? Are there other people that we need to involve in your care to allow you to have the best pregnancy care and the best outcome for parenthood? So I think because women with disabilities are not expected and encouraged to talk about and consider their fertility and parenting, they don't receive the same types of education. Next slide. All of the case examples I'm going to give you are patients of mine, and they're all patients that I've actually seen within the last year. Lisa was a 26-year-old young woman with Down syndrome, quite high functioning, completed high school, was working at a grocery store. I actually had plans to go back and try and study to be an early childhood educator. She had a boyfriend who also identified as having an intellectual disability. And she did express when we were talking about, are you sexually active? Is it consensual? Are you using contraception? That she wanted to have children in the future. And I had seen her previously as a teenager for menstrual suppression. I saw her as she became sexually active and talking about contraception, talking about STI screening, talking about pap smears. So her mother actually booked an appointment to see me alone, not with her daughter, because she wanted me to, because she knew that I'd had a rapport with Lisa since she was a teenager, to explain to Lisa that she should not get pregnant. Next slide. So obviously, I've known this young woman for a while. I have a sense of her level of functioning. I have to know whatever other comorbidities she may have that may influence health of a pregnancy. I need to understand her current relationship, and sometimes you do have to really explore: is it consensual? Is there abuse? But I had to involve another person here. I had to definitely listen to Lisa's mother's concerns and fears. Like, she is worried for her daughter. She, is worried if her daughter can have the ability to parent. She is worried about becoming the one who is going to be raising the child along with caring for her adult daughter with a disability. She had financial concerns. So I had to explore what her issues were as well as part of this team. And then I had to, sort of involve, and I eventually did, Lisa's partner and his understanding, desires, and support. And all of this took a lot of time and a lot of education, and a lot of times things that I couldn't actually bill for. So you have to be prepared for some of that. Next slide. I will say with her, she's still using Mirena, a progesterone-containing IUD, and has not yet pursued pregnancy. Susan touched upon this in terms of there are legal protections against involuntary sterilization. Obviously, if you are doing something that would cause sterilization, such as an ablation or a hysterectomy, it has to have a medical indication, and in most places has to require some involvement of the court to be able to prove that you're doing this for the person's well-being. There's often an assumption that, like with Lisa, that somebody with a disability can't be a parent, aren't able to raise children. And this leads to lack of preventative care before pregnancy, so counseling around preconceptual, folic acid, making sure that all other health issues have been addressed. If somebody has thyroid issues or diabetes or cardiac issues, that these are not going to impact on maternal or fetal well-being. And I think that Susan again touched upon the fact that medical health providers, that residents, we don't learn a lot about sexual health and pregnancy in our training, but we also don't provide this education to women with developmental disabilities because we assume that they aren't going to become parents. So we have to make sure that they are not subject to abuse. That they again receive the same reproductive health care as everybody else. And with support, women and men with developmental disabilities can be effective parents. Next slide. Next slide, please. So in terms of preconceptual counseling, we have to obviously ascertain knowledge of pregnancy, desire to conceive now or in the future, what their support system is, and we have to talk about, contraception before and after. We have to understand that they may have health behaviors that could impact negatively upon a pregnancy. Certainly, when you look at the literature, smoking, substance abuse is higher often in populations with developmental disabilities. Substance abuse can be higher. Things like just general well-being and exercise and health status may need to be improved upon before somebody enters into pregnancy. We want to focus on reproductive choice, and we want to make sure pregnancies are planned and that they will get early and appropriate prenatal care. And certainly there have been a number of studies that have shown that a lot of times people with developmental disabilities present to care much later, often missing some of the important preconception and first trimester care, either because they're worried about the stigma attached or they've had negative experiences with the healthcare profession in the past, or because they don't have the understanding of the need to present earlier. And so it's something that we have to be educating from very early on. Next slide. So we know that these are risk factors. Increased use of tobacco often have poorer preconception health. There's increased risk of mental comorbidities, obesity, diabetes, lack of social supports, higher rates of intimate partner violence, increased financial instability that can impact housing, diet, ability to access their appointments because of where clinics are located or hospital locations. So all of these need to be addressed. They often have lower education levels or lower ability to understand some of the written material that might be provided. And it has been shown, at increased risk for pregnancy complications and adverse pregnancy outcomes because of all these preconceptual factors that need to be addressed before pregnancy. Next slide. This was, again, a young woman who is a patient of mine with known intellectual delay. She has a 3-year-old daughter. She lives with her mom and sister. She's unemployed, receiving social assistance. So she presented for her first prenatal visit at 18 weeks by last menstrual period. And she had not had any previous prenatal care in this pregnancy. She was with a new partner who she did not live with. As I said, she lives with her mom and her sister. And this pregnancy was unplanned, but when discussed with her, was wanted. Next slide. So obviously it became important to obtain a medical and past obstetrical history. In her previous pregnancy, she had also presented late to prenatal care. So she presented in the late second trimester in the last pregnancy. She'd not had preconceptual folic acid. She'd not had the ability to have genetic screening offered to her. And I wanted to spend some time talking to her about her past obstetrical experience and concerns, because she felt that she was not treated well during pregnancy. She felt that she was often discriminated against, that people made comments about her being pregnant, that she should consider permanent contraception, that she shouldn't have more children. And so she already came in sort of very timid, very worried that I would be judgmental. First thing she asked, we have what's called CAS, and she was very worried that we would involve child protection and try to remove her current child, try to possibly make it so that she couldn't parent this child. And so she came into this with a lot of preconceived ideas based on her very real experiences of her last pregnancy. And this is despite the fact that her 3-year-old is healthy and thriving. She has actually fairly good social and family supports. And even though this partner she wasn't living with, she denied any abuse, and the partner actually came and participated in the antenatal care. And so over time, I was able to gain her trust, to have her come regularly for appointments by supporting her decision to keep this pregnancy and to become a parent again in a respectful manner. And over time, we developed a very good rapport, and she had a great obstetrical experience the second time around. Next slide. So, part of our job in pregnancy is a lot of counseling around the need for prenatal care, using pregnancy education classes. We have access now to online education. Making sure that education is going to extend into the postpartum time, looking at parenting classes and supports. I have some involvement with an excellent place called Surrey Place in Toronto that supports women with autism and intellectual disabilities. And I will be participating in some postpartum teaching for women with children who have the women have intellectual disabilities, and they've gone through pregnancy and have children. And so, being involved in education from the preconception through pregnancy and into the postpartum time becomes very important. Addressing all the barriers that could exist towards attending appointments, making sure education is repetitive and clear, referring early to support services. We involve social work, and we involve nursing care, and we make sure that that they have met some of the caregivers who will be involved in their care during pregnancy and during labor and delivery. And this requires longer visits and more frequent visits and a larger multidisciplinary team, and you have to be prepared to sort of provide that in order for them to have a safe and excellent outcome for their pregnancy. Next slide. This is one of my latest pregnant patients that I had to deal with, and I have been involved with her in her previous pregnancy, and she's difficult, and I have learned through her how to be a better teacher. She has a hearing loss. She does have bilateral hearing aids. She identifies as having a learning disability. Her last pregnancy was unplanned. Her mother was very, very involved with the prenatal care, and her mother actually provides a lot of the care for this child. Her mother desperately wanted me to tie her tubes. She requested that. Her mother really wanted me to provide some sort of LARC, either an implant or an IUD, because she felt that the risk for her getting pregnant again quite soon after was very real. So I've spent a lot of time with the mom coming to me with concerns and with this young woman. So she came in a new pregnancy with her partner, who she doesn't live with. And there had been issues of partner violence. And a year ago, there had been a restraining order against him. And she had actually at one point come saying she was trying to get pregnant with a new boyfriend, but actually then came with this partner. So to be honest, I'm not even clear necessarily who the father was. But when she came for her first prenatal visit, which we did a dating ultrasound, it showed a small gestational sac, too early to see a fetal heart rate. So I had her repeat an ultrasound, and it then showed just retained products of conception, suggesting that she'd had a miscarriage. And as she presented for this second ultrasound, she says she's been bleeding and shows me pictures of blood clots. Next slide, we start the conversation about miscarriage. So first of all, she's in the office with her partner, the same one who's been violent in the past. They're sitting very close together. They're holding on to each other. So there wasn't really at that point an opportunity for me to speak with her alone. They both said it's planned, it's wanted. And then I started to explain to them that between the two ultrasounds and the bleeding, this was consistent with a miscarriage. And again, we assume that people will understand the term miscarriage. They did not. They did not know what this term meant. They did not understand that this miscarriage, abortion, pregnancy, loss, and they really just kept saying, well, is the baby going to be okay? It took a long time, a lot of explanation, me drawing a lot of pictures with a baby in a uterus, with nothing in a uterus. And by the end of that, when I started briefly to talk about the fact that she had retained products of conception and what some of the management options for that would be, I could see that I'd lost them, right? They finally were starting to get that this was not going to be a pregnancy that was going to continue. And I couldn't continue this conversation at that time. And because she was stable, I sent them away to come back in a week with a repeat ultrasound so I could really explain this again to them. She went on to pass all the products of conception, did not need any further treatment, and has not yet returned, unfortunately, yet to discuss, again, preconception counseling and or the use of contraception, or for me to have an opportunity to talk to her privately about the fact that this was a partner in the past who was violent. So, a work in progress, this case. Next slide, please. So during pregnancy, sometimes what we also have to spend a lot of time is just talking to people about what they're going to experience, that they are going to gain weight, that they're going to have possibly nausea and vomiting. We have to talk about lifestyle and make sure that they understand the signs and symptoms of things that could be negative, that we have to screen for mental health throughout the pregnancy, and then discuss in advance required tests, things that are sort of part of routine care provision, and things that they may have options to discuss, such as genetic screening. And always we have to be involving all the partners in care that can help to contribute to a healthy pregnancy. Next slide. We have to prepare for intrapartum. We have to discuss signs and symptoms of labor. Pain management is a big one, what they can expect, what the options can be for providing pain control, maybe meeting anesthesia and doing a consultation in advance. Talk about the fact that what's a vaginal delivery, when an operative delivery such as vacuum or forceps might be required, or C-section. So none of this is as a surprise to them. Often it's very important for them to tour labor and delivery in advance and discuss transportation needs if they go into labor in the middle of the night. So all of this has to be pre-planned. Next slide. And they have to understand symptoms and signs of labor, and labor support people have to be involved. Again, slow, clear, repetitive instructions. And this has to be done before, during, and after labor and delivery. Next. Postpartum, we need to have social supports in place. We need to have links to community services and parenting support. These people almost expect that you're going to try and remove their child from their care if you involve agencies. And so trying to explain to people that we're trying to support the family unit rather than assume that we're trying to tear it apart. They may need a longer hospital stay. They may need more education around breastfeeding. We need to be monitoring more carefully mood and risk for postpartum depression. And then all the logistic things that are required in terms of taking care of a baby, supplies and stuff need to be in place before. Next slide. So pregnant women who have intellectual or developmental disability need education, and more education. They need lots of support. They need lots of repetition. They need extra visits and more time. We need to involve many personal and community supports. And we need to, above all, have respect for their decision making and allow them to have autonomy in their care. Thank you.
Thank you both. That was absolutely wonderful. And now we will turn to some questions from our audience. I see there are already a couple of questions in the chat. The first question, I think, is directed toward you, Dr. Ernst. This person asks, I am interested to know how this approach works with insurance. This is clearly an American, for an American setting, not Canadian. For example, if the patient comes and just lies down on the table, but then wants to come back another day for the actual exam, does that mean that the family is charged for multiple visits?
Yes, they would be. I would do the initial as like an intake visit and not charge them for the physical exam portion. And then when they return, I would charge them a lower fee for a return visit with the physical exam.
Okay, thank you. These kinds of practical issues can be important at times. And so thank you. We appreciate the question and thank you for that answer. And then here's a question I think makes sense for both of you, which is that how did you go about educating your other colleagues and other departments on how to deliver inclusive and accessible care? We've had difficulty doing that at our institution, especially for radiology, pharmacy, and labs. And perhaps we can start with Dr. Ornstein.
Well, I work in a practice that has a huge new immigrant population and a lot of women who have English as a second language or don't speak English. I have a partner who does a lot of transgender care. And then I have a population of women with developmental disabilities. And so we've made it our mission in our hospital setting to try and use the other partners available for care. We have an excellent midwifery department that are great at providing supportive care. We involve our social worker and our nurse practitioner. We do a lot to do early tours and to talk to the other care providers about the need to provide slower care, more explanation. And it's a work in process because there are still people who sort of show their biases and don't, want to provide care differently than they would provide for anybody. I think it's just a lot of discussion and a lot of education towards the other people who will be involved.
Thank you. And Dr. Ernst?
Yeah, as I mentioned, I've been doing this work for over 18 years, and it was a struggle in the beginning, feeling isolated, like nobody else was doing this work with patients with disabilities. And so I would reach out to anyone I met who had an interest. I met a pharmacist who had a son with disabilities, and he was starting to do some disability research. And I met a family medicine doctor who had hearing loss. And I reached out to him and asked about his research. And eventually, from these sort of organic relationships, over years, the Center for Disability Health and Wellness was started. And we have been able to sort of harness that power, and the people in multiple specialties who care about giving good healthcare services to patients with disabilities. And in addition, our university, and I think really across our country, people are really embracing DEI work, so diversity, equity, and inclusion work. And we've been asked more and more times to give lectures at various institutions in different departments, PM&R and pediatrics. And so we just accept that invitation to go give a talk whenever we can, so we can share our experience and how patients present to us, telling us about the sometimes horrific healthcare experiences they've had, and just sharing that so that people will understand that everything that you say and do really matters in supporting these patients.
Thank you. And that seems to be all the questions that we have, but so I'd like to move on to the next slide, where I think we have a list of resources. Of course, the National Research Center for Parents with Disabilities, the Disabled Parenting Project, Rocking the Cradle, Child Welfare Information Gateway, and several others. And I'd like to note that in the chat, Leslie Tarasov, who's done a lot of really excellent work in this field, notes that her organization, her university, has created some resources based on the research in Ontario, Canada, and that they have some resources online that include many of the tips, the things that they've learned. So if you just click on that link, it will take you to their webpage. And they really do. I have seen it, and it does have some very helpful tips. So let's move on to the next slide.
Did that work?
No, that's all right. I think that we are done for today. Really and truly, this was really wonderful, and it was sponsored by the National Research Center on Parents with Disabilities and Their Families, which is a cross-disability initiative guided by the ethos of the disability community, nothing about us without us. And I want to thank you both for this presentation, and to thank the National Institute for Disability, Independent Living, and Rehabilitation Research and the Lurie Institute for supporting this webinar. Thank you, and have a great day, everyone. Bye-bye.
Thank you.
Thank you.